Ladies and gentlemen, thank you for standing by. Welcome to Webinar Wednesday, Health Equity, Theory and Practice in Kentucky webinar. During the presentation, all participants will be in a listen-only mode. If you'd like to ask a question during the presentation, please use the chat feature located at the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Wednesday, February 26, 2014. I'd now like to turn the conference over to Rochelle Seeger. Please go ahead, ma'am.
Thank you so much. Good afternoon, everyone. Thanks for joining us. I'm Rochelle Seeger, Community Health Research Officer here at the Foundation for a Healthy Kentucky. Thanks for joining us today. This webinar is part of the Foundation's Health for Change training series. This free series is comprised of webinars and in-person workshops designed to support the efforts of Kentucky's community health coalitions, agencies, health advocates, and interested community members. The Foundation for a Healthy Kentucky was founded in 2001. With a mission to address the unmet healthcare needs of Kentuckians with three main focus areas. Promoting responsive health policy aims to make public health policy more responsive to the health and healthcare needs of the people of Kentucky. Investing in Kentucky's future aims to improve the health of Kentucky's children by engaging communities in tested, innovative strategies. And supporting communities aims to support implementation or expansion of innovative strategies to improve the health of Kentucky's lower income communities. The Foundation does this by grant making, supporting targeted health and healthcare related research, providing policymakers with the information needed to make decisions which impact the health of Kentuckians, and by offering training and technical assistance through events just like this one. The photo you see on your screen is of a fall evaluation workshop we held in Lexington. You can see it was extremely well attended. Next, I'd like you to mark your calendars. The Health for a Change training workshop to be held March 14th here in Louisville at the Foundation offices will be on business planning. There we'll have an expert on business planning who will talk you through the basics of writing a business plan and how to make it successful for your audience. Today's webinar will talk about health equity. I'm honored to welcome three experts on this topic. They will describe aspects of health equity, including the definition, theories, and research about this topic, and we'll conclude the webinar by hearing the activities and updates from the Kentucky Office of Health Equity. As the moderator mentioned, we'll have questions and answers, so please send those via the chat box. Finally, I want to let you all know that all of the Foundation's training series are archived on our website by video presentation. We have a great training series on health data. In December of last year, we did a training series on advocacy versus lobbying, where we had a lawyer talk about the differences between those two. Again, those are free and welcome. You're welcome to check those out on our website, healthy-ky.org, under the video section. Now, I'm honored to introduce our first speaker this afternoon, Gabriela Calde. Gabriela is here at the Foundation. She's the Health Policy Director. She has diverse public health experience in government, nonprofit, academic, and community sectors. She's been active on boards and coalitions addressing public health policy, health equity, and communities of color. She holds a doctorate in public health administration from the Department of Health Policy and Management, Gilling School of Global Public Health, University of North Carolina at Chapel Hill, and a master's in public health from Boston University. I'm so honored to introduce Gabriela. Welcome, Gabriela.
Thank you, Rochelle. Hi, everybody. Good afternoon. I am going to, as Rochelle said, going to provide a little bit of an overview and background on health equity, just to set the stage for Amira and Vivian as they talk about some specific projects and research going on in Kentucky. So next slide. I like to start my presentations with definitions and also by sort of airing any preconceived notions or assumptions that I make, and also by just setting the stage. So this first slide is just a statement of where we need to start when we're talking about health equity. The recognition, and this is sort of based on facts that we've known for decades now, this is not contested anymore, but we sort of all need to start on the same page of understanding that health and illness are not distributed equally or equitably among people. Among different groups of people. So starting from that point, we're going to explore what health equity is. The next slide provides a couple of definitions that I like to use. Health equity is one of those terms where there are endless number of definitions, and over the years they get refined. But there's some that sort of stand strong. Overall, you could say that health equity is about making sure that opportunities, resources, and power are distributed fairly among all populations. Two definitions that I think really address the gist of the term and the concept are a short one by Margaret Whitehead, and the other one is Healthy People 2020, which is our national roadmap for health. Margaret Whitehead actually describes health inequity, so we're describing it in the negative, by saying that health inequity are the differences in health that are not only unnecessary and avoidable, but they're also unfair and unjust. Some key terms within the Healthy People 2020 definition that I like to point out is that it talks about achieving the highest level of health for all people. It doesn't say that everybody will be in great health. It's simply the highest level of health for all people. And health equity entails focused societal efforts. So these are not things, we're not talking about individual level efforts. We're talking about societal efforts to address avoidable inequalities, so things that can be prevented, by equalizing the conditions for all health groups. And two terms in there, the conditions for health and groups. So when we're talking about equity, we're talking about the environment. We're talking about changing the things that make us able to make decisions and take actions. And we're talking about groups again. We're not talking about individual level, which is where we often get stuck when we're talking about health. On the next slide, a little bit more about health equity. Basically, I'm sure you have heard about people talk about health disparities, and oftentimes people use the word disparities and inequities interchangeably. However, these two are pretty different, and I'm going to hopefully convince you that not to use those two terms interchangeably, as they mean quite different things, and they can lead us to develop very different policies and programs. So basically, inequities are differences that are preventable and unfair. And while we want to work towards decreasing disparities, that alone will not provide for health equity. So that's just one part of what we'll be talking about. For Healthy People 2020, eliminating health disparities has been a national goal since 1990. And that's a very important goal. However, that alone cannot achieve health equity. And that's an important thing to remember as we think about this concept. On the next slide, just a reminder that inequities exist across many dimensions and that none of us are unidimensional. So all of these factors interact. When we're talking about inequities, we've got to look at our identities and our existence in race, income, gender, whether you live in rural areas, your educational level, your immigration status, sexual orientation, social connectedness, your disability status. And obviously each one of us has a number of these and that defines us in very different ways. We fall into broad groups, and so when we look at inequities and also at disparities as a way to measure them, we need to consider all of these areas. Oftentimes, when we talk about disparities and inequities as well, we limit ourselves to talking about racial disparities. However, we need to consider each of these because there's extensive research showing disparities and inequity in all of these dimensions. On the next one, we get to the issue of measuring equity. I'm sure you've heard that unless you can measure it, it doesn't really exist. And in research, as well as in funding, we often get asked to measure things. How do we know things have changed? How do we know that there's improvement? You can't actually measure equity or inequity. We can measure disparities. And that's where it's really important to understand the relationship between the two, but to not confuse the two. We can measure the fact that health and illness are not distributed equally by looking at health disparities, and in that way understand inequities quite a bit. The U.S. Department of Health and Human Services has a definition for disparities, differences in the occurrence, frequency, death, and burden of diseases and other unfavorable health conditions that exist among specific population groups, including racial and ethnic minority groups. Now, why is this important? For one, I think from ethical perspective is very important, but two, just from a practical perspective, in the U.S. by the year 2045, more than half of the U.S. population will be people of color. So it's important to understand because majority of the population in the U.S. will be people of color who at this point do not have the advantage of having the optimal health that they could have. And the next slide. So here's sort of the take-home message from my part of the presentation. If you remember anything, remember that equality is not the same as equity. They are different but related. Inequalities are often inequitable, but they not always are. Sometimes there are reasons why there are differences. What we are interested in finding out is to ask why there are differences, and if those differences are preventable and they are unfair, then we can classify those as inequitable, and then we want to take action. On the next slide, we're going to start talking about, so what do you do once you've asked a question? Why is there a difference? Well, once you know that there's a difference, you've got to talk about why is something happening, and you have to put that through the lens of fairness and justice. Now, equity is about fairness. It's about fair distribution of opportunities and resources in health. But fairness is a moving target, and it has a lot to do with our values. It has a lot to do with our culture. It has a lot to do with what's available to us. It also has a lot to do with where you are in society. As a society, we might decide that something is fair, and for specific groups, that may seem profoundly unfair. So it's important to remember that fairness is subjective. So when we're doing health equity work, some people will not agree with you. And this is an important thing to remember because it can get kind of messy. On the next slide, I want to make this a little bit more concrete. I know we're sort of talking up in the clouds right now. So I thought what better way to do that than to talk about food and make it very concrete. So what we're going to do right now is imagine that this pie represents all of the resources and opportunities in our society. So these are the opportunities we have to access things that we need in order to be healthy. And we're going to ask ourselves, how many ways can we split this pie among us? So if we look through an equality framework, which is a very important concept and framework in the U.S. and a very valuable one, equality would say, well, we should cut this pie up into equal sizes. Everybody should have the same size slice. That would be fair if you are thinking of it from an equality perspective. Doing it that way, it assumes that we all start from the same point, that we have the same needs, the same opportunities and resources, and we should therefore receive the same amount of pie. Now on the next slide, we have to ask ourselves, if our goal is for everyone to be equally well-fed or equally full or equally nourished or equally happy, and again, you have to agree according to your goals what your outcome is. If you cut the pie into equal slices, you're not going to get an equal outcome because we start off at different points. Again, it gets back to our first slide where we acknowledge that health and illness are not distributed equally among people. So distributing resources equally is not going to get us equal outcomes. And this is why it's very important when we're talking about health policies and health programs and interventions that we think of things through an equity lens and not through an equality lens. On the next slide, we explore some questions that you could consider. So if you want to actually distribute resources and opportunities according to equity instead of equality, because you want everyone at the other end to come out with a more even playing field, and you want the conditions to facilitate people having equal access to health, then equity would have you ask a number of questions. For example, you might ask, who's the hungriest? And maybe the hungriest people should get the biggest piece of pie. But then you get into, well, how do you decide who's hungriest? So this is where, again, having data and having measurement is very important. You could ask yourself who hasn't eaten today or who won't eat again today, and maybe those people get the biggest piece of pie. You could talk about justice from another perspective and talk about, well, if there's somebody here who wouldn't be able to eat pie otherwise or who's never had pie in the past, or who needs the most calorie? Are there young people that are growing? Are there pregnant women? So there are all kinds of questions you can ask yourself. And again, this is all defined by the values that you have in society. This is why health equity might look different in one country versus another, or even in different parts of the U.S. Now, that doesn't mean that something can be wrong in one place and right in another. It just means that how you develop your programs and your policies for health equity isn't necessarily going to look the same everywhere, because it is influenced a lot by your societal values and your culture. I'd like us to move to the next slide to look. There are a couple of frameworks that I wanted to share with you. Some of us are more visual learners, so I wanted to give a couple of different ways of looking at equity and how policy plays a role in equity. The CDC has this health impact pyramid, and it helps us think about different factors that affect health. So this is another way of thinking about how policies and programs can affect, promote, or undermine health equity. The biggest changes when you look at this pyramid in any action that we take are resulting from changes at the societal and policy level. Now, oftentimes when we think about doing something for health, we think at the very top of the pyramid. We think about education, we think about going to the doctor, we think about individual behavioral change. Now, these are important things, but as you can see from this pyramid, that actually has the smallest amount of impact. So if you want to really look at how do you really promote health equity, we are looking at the bottom of the pyramid. We're thinking about changing the context. We're thinking about changing policies. For example, smoke-free laws, which right now Kentucky is considering. We're thinking about housing, poverty. We're thinking about education. We're thinking about economic well-being. So these are the things that make the biggest impact. On the next slide is another way of looking very similar to this pyramid. For those of you that think more in a flow chart, in public health we often talk about upstream and downstream. Upstream is sort of going to the source of things. Downstream is further down once problems have already developed. This is called a framework for health equity, and I don't know how well you can read what's within each of them. But when you look at upstream, this very much looks like the bottom of the pyramid. So this is where those factors that really affect your health the most. So the bottom of the pyramid or the left-hand side of this framework are both where you have the biggest impact on your health and also where you can make the biggest impact on promoting positive health. And that is just not how we're used to thinking about it. So when we're talking about equality, we're often working more in the downstream in the medical model and providing equal access to people. When we're thinking within health equity, we really are thinking and working more on the upstream parts of things. We're thinking about more policy changes, environmental changes, changing of social norms. So speaking of policy, I'd like to just touch on that before I hand it over to the other presenters. In terms of health equity and policy, an important thing that lately especially there's a huge recognition is the health in all policies approach. Now this has been around for decades in the rest of the world as well. Just the recognition that health is affected by all policies, not just health policies. And when you look at the pyramid or the health equity framework, you can see that the biggest impact on health is actually not through health. It's through housing, it's through the physical and social environment, it's through your economic and educational level. So policies can make inequities worse, they can maintain the status quo, or they can help correct inequities. And if you inform policy development as well as program development through your understanding of health equity, you can actually address the causes of it, the causes of disease and health, and not just the outcomes. When we're working downstream, we're trying to correct the outcomes rather than correct the causes. So just briefly, thinking about how do you bring a health equity lens to your work, because this is all sort of, I'm covering the sort of the theory of it, which seems like maybe it's hard to apply to your work. But if you view your work through an understanding of health equity and you use one of those two frameworks, you can ask yourself, why are there differences in the outcomes or in the access, whatever the measure point is, to the populations that you serve? Maybe there's a way of delivering services and information that can change, the way that you measure outcomes, that you do your evaluation, how you communicate about the issue, even simple things like how you fill out reports, how you interact with clients and patients, and how you incorporate prevention into your work, again, moving further upstream, and how you engage the community. In order to affect health equity, you have to change the context. So the goal of health equity approaches is to eliminate or reduce unfair and avoidable inequalities by addressing the root causes of inequalities. Again, inequalities or disparities are not the same thing as inequities, but we need to measure them to have a sense of where we are. Improving health outcomes rate alone is not going to address inequity, but it's a way to get there. In order to address inequity, we have to remember the broader context, the framework that we saw there, sort of the social, the cultural, and the policy level. Now I wanted to wrap up with just bringing us back in Kentucky. So inequity in Kentucky. We know that health is not distributed equally among populations in Kentucky. We can see that through our different statistics on our website. The differences in health cannot be explained by biological differences, so we know that they are preventable. We know that they are avoidable. And there are social and economic reasons for these differences in health, so that means that they're also not fair. Healthcare is a big part of the solution, but it is just one part of the solution. We've recognized over the years, next slide, that where you live, work, play, and learn matters when it comes to health. And because not all people have access to opportunities and resources to attain their best health, Kentucky is losing out on opportunities and is paying large sums of money to treat these unnecessary illnesses and injuries rather than preventing them by addressing health inequity, by creating changes at the societal and policy level. And again, this is why it's so important to address things from a health equity framework, even if you're doing work at the individual level, having an understanding of why people have those health outcomes and understanding the root causes can help shape policy, and it can help you shape your programs. The final slide I have is just some health equity resources to share with you, looking at different approaches to health equity. How do you institutionalize health equity? Looking at different types of prevention. The Prevention Institute, there's some great documentaries and videos on unnatural causes. And I've provided a list of other ones both within Kentucky and at the national and international level. So you can go in there and sort of get a better understanding of health equity approaches and how you can take this sort of theoretical, conceptual level approach and apply it to your everyday work. Thank you very much.
Thanks so much, Gabriella. And if we want to even extend the pie metaphor a little further, what if the people we're serving maybe are allergic to pie? So we're actually doing damage by serving them pie, right? So that's a really interesting metaphor. I'm honored to next introduce Amira Abdullah. Amira is a third-year doctoral candidate with public health at the University of Kentucky. She is pursuing an academic concentration in epidemiology along with a certificate in maternal and child health, and would like to pursue a career in epidemiology with a focus on this area, health disparities, as well as public health preparedness and response. I'm honored to introduce to the call today Amira. Welcome, Amira.
Thank you, Rochelle. Good afternoon, everyone, and thank you for joining us today. Today I'm excited to share with you the work the Council has been doing to improve health equity in the Southeast region of the United States. Next slide. On the agenda for today, I want to start by briefly providing information about the Southeastern Health Equity Council. Then I will discuss in detail the Health Equity Report Card, provide next steps on what we all can do in our communities to improve health equity, and I will complete my presentation by providing you with the resources that may be helpful for you as you work to improve health equity in your community. Next slide. So a little bit about the SHEC, or the Southeastern Health Equity Council. It is one of 10 regional health equity councils in the United States formed in 2011 to implement the National Partnership for Action to End Health Disparities, which is also known as the NPA. The NPA is a collaborative that was started in 2011 by the U.S. Department of Health and Human Services to establish and mobilize a nationwide, comprehensive, community-driven, and sustained approach to combat health disparities and to move the nation towards achieving health equity. The SHEC's vision, part of the NPA, is to have a region free of disparities in health and healthcare, where all people can attain the highest level of health. So as we work towards achieving that vision, our mission is to coordinate efforts in the southeastern region to achieve health equity through policy changes, effective programs, and greater awareness on the issues plaguing individuals and our communities. Next slide. So here is a map illustrating all the regional health equity councils in the United States. The region that the SHEC responds to is Region 4, which consists of Alabama, Florida, Georgia, Kentucky, Mississippi, North Carolina, South Carolina, and Tennessee. And currently our regional office is located in Atlanta, Georgia. Next slide. So now knowing what states we represent, I think it's very important that we provide context on why health equity efforts in the Southeast are so important. In 2011, more than 61 million people resided in Region 4, making us the largest population compared to other regions of the United States. 37% of our population consists of minority populations, with more than 13 million African American or non-Hispanic blacks residing in the population. Region 4 is home to the largest minority population in the U.S., and there is currently no other region that has a higher prevalence of minorities than the Southeast. In addition, 17% of our population is living in poverty, which is higher than the national average of 14%. And lastly, Region 4 ranks second at 21.9% behind Region 6 for the percent of those living without health insurance. Next slide. In 2010, it was reported that roughly 21% of U.S. deaths U.S. deaths for heart disease occurred in Region 4. And we know that research tells us that factors such as obesity, diabetes, and hypertension are contributors to heart disease. And those are some of the main factors that affect the Southeast population. In 2011, 28.9% of adults living in Region 4 were obese, compared to the other Department of Health and Human Services regions, who averaged roughly around 26% of its adult population being obese. In addition to that, in 2011, Region 4 ranked number 1 in diagnosed cases of diabetes and in hypertension. If you look at the map on the right, you will notice that compared to all other regions, Region 4 experiences higher cases of diabetes, which places individuals at an increased risk for heart disease, blindness, and kidney failure. Next slide. So for these reasons, the Southeastern Health Equity Council wanted to develop a health equity report card that would identify where health disparities exist for our key priority areas, which are healthcare access, healthy food access, and cultural competency. Next slide. So the Southeastern Health Equity Council will use this report card, which will be released in April of this year, to inform a range of decision makers in the public and private sectors through electronic distribution of webinars and targeted dissemination on how our region is doing when it comes to health disparities. Using this report, we want to engage policymakers in a conversation to leverage upstream approaches which impact many of the negative indicators found in the Southeast. The report card is positioned to inspire the production of additional reports and highlight the need for data collection and sampling issues among underserved populations. For this reason, each indicator on the report card will be measured by race, ethnicity, gender, urban-rural status, sexual orientation, and disability status. We understand that all data will not be available for all these subgroups. However, we wanted to illustrate to policymakers the importance of collecting data for the gaps the gaps that currently exist in health disparities and data collection so that it can impact some of the populations that we serve and allow us to better serve the populations in need that we currently do not know much about. Next slide. So here are a few key findings that we found by each priority area for our report card. The southeastern region illustrated that roughly 74% of its population, age 18 to 64, had health insurance, which is lower than the national average. And one of the reasons for that is only 68% of blacks or African Americans and 54% of Hispanics and Latinos that have health insurance compared to 78% of whites. In addition, Kentucky is the only state in the southeast region that has opted to expand its Medicaid program with funding from the Affordable Care Act. This allows Kentucky to provide more low-income individuals access to health care services that the other states in the southeast region cannot do as of yet because they failed to expand their Medicaid services. Kentucky is also the only state in the southeast to create a state-run health insurance exchange under the Affordable Care Act. Next slide. Some of the key findings that we found among the food access indicators in the report card is that all of the southeastern states scored an F in food insecurity, meaning that there are many individuals that have reduced quality, variety, or desirability, or even access to healthy foods in their communities, which can lead to malnutrition and nutritional deficiencies among our population. In addition, most of the states scored poorly on the percentage of the population living in food deserts, which means that a lot of individuals in communities are roughly 5 miles away from a grocery store that provides healthy fruits and vegetables services. In addition to that, the data illustrated that all of the southeastern states scored poorly on the consumption of fruits and vegetables, physical activity, obesity rates, and diabetes rates, with clear disparities for these indicators. So if you look at the table on the right-hand side, you will see that this is an illustration of one of the tables that are included in our Health Equity Report Card, and it shows the disparity that exists among people who engage in physical activity. I believe it's 30 minutes of physical activity 3 times a week in the southeast region of the United States. And we're comparing that to the national average. And we notice that many of the states in the southeast and the overall rate of people in the southeast who engage in physical activity is pretty low. So we need to implement programs. We need to facilitate services to try to encourage people to engage in physical activity so that some of the chronic illnesses that are associated with the lack of physical activity can also be reduced in our region. Next slide. Here are some findings based on the cultural competency indicators that we included in the report card. And we found that in doing our research, this region is home to a growing American Indian, Appalachian, and impoverished population. In addition to that, Region 4's minority population continues to grow at a higher than expected rate. In order to provide quality and safe services to this population, the workforce must match it in its dynamic and diverse qualities. For example, South Carolina currently stands at number 1 for the growth of the Hispanic population. This further illustrates that there is a need for our workforce to expand its cultural competency in order to tend to the needs of this population. Cultural competency education helps healthcare providers be responsive to diverse cultural beliefs and practices, preferred languages, literacy and health literacy levels, and other patient needs. Now, although a law requiring cultural competency education in healthcare professional training programs has been proposed in many of the southeastern states, as you see in this map located to your right, there has yet to be any state in the southeast to pass and make make it required for healthcare professionals to receive cultural competency education. Next slide. So after completing the report, the Southeastern Health Equity Council came together and said, what can we do moving forward to ensure that we are improving health equity in the Southeast and eliminating step-by-step some of the health disparities that exist. And so some of the things that we thought were important to do is to make sure that all states expand Medicaid and coverage through the Affordable Private Health Care Insurance Plan initiated with the Affordable Care Act. Expanding Medicaid and coverage through affordable private health insurance plans in the southeastern states would contribute to lower mortality rates due to life-threatening conditions and lower the overall health care costs through prevention and proper management of chronic conditions. In addition to that, we thought that it would be important to develop and implement food financing programs at the state or regional level. In implementing these programs, we believe that it could potentially increase access to full-service grocery stores in areas designated as food deserts or food insecure populations and communities. Also, we think that it's extremely important to increase the competency of the healthcare workforce. State-level laws and/or licensures or certification policies should be enacted to require that cultural competency education is provided to new and existing healthcare professionals. And lastly, we truly believe that it is important to collect data on diverse subgroups of the U.S. population. As you probably saw in the table on physical activity, there are a lot of gaps in data collection and a lot of missing data. Failure to collect data on social and demographic populations limits the ability for us to identify disparities and track changes over time in health outcomes and factors that impact health among diverse subgroups of the U.S. population. Next slide. So to learn more about the SHEC and to access additional information about what we're doing in the Southeast region, if you want to become a partner of the Southeastern Health Equity Council, please feel free to visit us at region4.npa-rhec.org. In addition to that, to stay abreast on all the SHEC-related activities and health equity events happening in Kentucky or in the other Southeastern Health Equity Council states, please visit and like us on Facebook. Next slide. So here's a great resource that I believe will help many of you improve health equity and eliminate health disparities in your communities, and that is the NPA website. This website has a guide to health disparities resources, which provides a list of contact information to regional OMH coordinators, public health service minority liaisons. It also comes with sources of health materials and other helpful resources to help you improve health equity. Two reports that I thought would be really helpful for implementing health strategies in your community are the Toolkit for Community Action and the National Stakeholder Strategy Report for Achieving Health Equity. Both of these reports provide a common set of goals and objectives for public and private sector initiatives and partnerships to help racial and ethnic minorities and other subgroups reach their full health potential. Next slide. So this completes my presentation. The SHEC appreciates your time and interest, and if you have any questions about the NPA, additional health equity resources, or information on how you can get involved with the SHEC, feel free to contact me at the email address provided. Thank you.
Thanks, Amir. It looks like we have a lot of work to do to raise our grade here in Kentucky. And to give us some more information about what's happening currently in Kentucky, I'm honored to introduce Vivian Lashley-Bibbs. She is the Acting Branch Manager and Epidemiologist for the Kentucky Department of Public Health, Office for Health Equity, as well as a State Coordinator for Healthy People 2020. The Office of Health Equity provides leadership and oversight on multiple projects that address health disparities, including cultural and linguistic competency, social and ecological factors of health on disparate populations, and disease prevention. Vivian earned a bachelor's degree in biology from Kentucky State University, a master's degree in hospital and molecular epidemiology from the School of Public Health at the University of Michigan. Welcome, Vivian.
Thank you, Rachel. Good afternoon, everyone. I'd like to follow up with the great presentations that have been done so far and just kind of try to connect the dots and try to surmise what we've heard this afternoon. A lot of good information, and kind of give you where my office sits in the scheme of things. I'd like to talk about two objectives that I really want you to take away this afternoon, and one of that is to gain an understanding of those social inequities that you've heard about and how they impact health and related health outcomes, and then to think about what strategies that we're using at the state level and what you can use in your local communities to address those social inequities that are linked to poor health outcomes. Just to give you a little history on the Kentucky Office of Health Equity, we were established in the fall of 2008. We are solely funded by the Office of Minority Health, and we use the NPA, the National Partnership for Action, as a guide to mirror their objectives to our objectives here at the state. Our focus is to eliminate health disparities among racial and ethnic minorities, rural and low-income populations across the state of Kentucky, while promoting health equity in the state as well. Some of the things that we focus on with the National Partnership for Action to End Health Disparities, and I'm hoping you're seeing that NPA slide, is a comprehensive community-driven approach organized by HHS to achieve health equity through our collaborations and partnerships with agriculture, commerce, defense, education, environment, housing, justice, labor, transportation, and veteran affairs, and to use those local stakeholders to help us identify goals that are the most important for our communities and adopt the best effective strategies. Next slide, please. If you'll look at the circles for the Kentucky Office of Health Equity, all of these intersect, and these are the 5 areas that we focus on. We look at awareness and creating our partnerships to extend our reach across the state. We work on strengthening and broadening our leadership, which is why hopefully you're on the phone on the webinar today, and that's to help address health disparities at all levels. And then we also do health and health system experiences, looking at access for racial and ethnic minorities in underserved communities. We look at cultural and linguistic and competency, including health literacy. And then we do research and evaluation, which is improving coordination and utilization of research and evaluation outcomes. Next slide, please, in summary. I love these quotes by researchers in the field where they say healthcare by itself does not guarantee good health. And I think you heard that from Dr. Calde earlier. And also there are other factors involved. And technology, as great as we like to think it is, there are other things such as nutrition, sanitation, and other basic human services that are just as equally important. Next slide, please. When we think about social determinants of health, and I think you've heard that described earlier as to where we live, learn, work, play, and even pray, we think about those things that they're not one-dimensional, they intersect, they're integrated, and can be very complex. Those include your socioeconomic status, discrimination, housing, your physical environment, food security, culture, social support, our healthcare services, where we work, and transportation. Next slide, please. And this is one of my favorite slides in trying to talk about social determinants, and that's my social determinant tree. If you look at the tree on the left, it doesn't look very healthy. And if it were me, I would definitely want the tree on the right growing in my backyard. The tree on the left is an indication of what happens when inequities are high and community assets are low. You can often see that the health outcomes appear worse. And in the root system where we don't have social support, we have poor quality of schools, we have high unemployment, we have poor neighborhoods, no parks and recreations for physical activity, that produces that kind of tree. In comparison to the tree on the right, when you have access to health care, when you have when you don't have food deserts, when you have clean air and water, when you have adequate housing, when you have great transportation, when you have great social support and community buy-in, that tree thrives. And even though you notice we haven't eliminated those chronic diseases and conditions, but they're minimized. I'd like to skip the next slide on the socio-ecological model in addressing health equity. You've heard something about that, and we won't belabor that. And also, just to reiterate what Dr. Alcalde highlighted as the CDC Health Impact Pyramid, it looks a little different here, but the concept is the same, that when we look at education, adults without a high school diploma or equivalent are 3 times more likely to die before the age of 65 than those with a college degree. Studies have also shown that white men with bachelor's degrees live 17 years longer than a black man who didn't finish high school. Also, we know that geography and neighborhood have conditions unique to them that can exacerbate health disparities, and environment with pollution and other environmental factors as well. So it's the bottom of the pyramid where we get our largest impact. That doesn't mean that we don't continue to do counseling and one-on-one education, but it just goes to show that the bottom of the pyramid where there's stability is changing the context to where healthier decisions become our default, and socioeconomic factors are considered to have the greatest impact on health outcome. Next slide, please. America's Health Rankings. I often, when I do presentations, like to be known for great things that Kentucky has done and not data that shows us in this slide. If you look on the slide, you can see that we're 50th for cancer, 50th for smoking. Our overall ranking in 2012 was 44th. If you look at premature death, we're 44th, and the list goes on. So when we look at those rankings and we want to look at disparities, if we focus on Kentucky, we have the highest smoking rate in the U.S. at 29.0% of the adult population, with more than 970,000 smokers in the state. There are more than 1 million obese adults in Kentucky, with an obesity prevalence among non-Hispanic blacks at 42.5% compared to non-Hispanic whites at 31.8%. In Kentucky, blacks also have the highest prevalence of diabetes, 14.5% compared to 12.8% in 2011 and 2012 respectively. So that gives us something to work toward. And if you go to the next slide on how do we narrow these disparities, we know they exist. So what do? What we need to do is to focus on improving the overall health of the population, target our efforts in improving the health of our underserved populations, and focus on improving the overall quality of care and closing the gaps for our underserved groups and racial minorities in the state. Next slide, please. So I've kind of put some questions for us to think about. So how do we address these disparities to achieve health equity? So what do we need to think about? The key factors for addressing health disparities should be looking at socioeconomic conditions, our social support and physical environments, our access to quality care, our cultural competency, that of our public health workforce, health literacy, and whether we are empowered healthcare consumers. Disparities are often produced through a chain of events around a medical encounter. So once a person gains entry into the healthcare system, we want to know whether that condition will require medical intervention. Will that diagnosis be appropriate and correct? Will the treatment be correct? Will it be administered correctly? There's so many steps in the process of receiving care and disparities that can occur around any step. So we must think of it as a hose with holes. Water comes out at each hole. People experience disparities in healthcare at many different points in that continuum. You can plug one hole, but there are many left. And you're not going to fix the hose with one patch because there's so many holes for the water to find an exit. Next slide, please. So how can I personally begin to address the many problems associated with health disparities? I think we need to focus on a place where you can make the most impact. Make your intervention as strong and effective as possible. And sometimes these disparities can seem to be overwhelming, and then many of them are not associated with the healthcare system at all. So it's helpful to recognize the largeness of the problem, but don't leave that to be a reason not to act. Next slide, please. So most of us know that our zip code is more of an indicator of poor health outcomes than our genetic code. And many times, those factors that are like income, our social support networks, our education, employment, and social environment are much stronger indicators of a poor health outcome than our DNA. Next slide, please. So what are we doing as a state and as a community to achieving health equity? Well, we're improving race ethnicity data. We're strengthening the capacity of state government and communities to sustain effective partnerships and develop programs to improve our racial ethnic health inequities. We're talking about social determinants and making that link to poor health outcomes through public education and evidence-based community interventions. We're ensuring equity access to quality health care, and we're strengthening our community engagement capacity and empowerment. Next slide, please. So how are we doing that in Kentucky? Well, the Office of Health Equity has been charged by statute to produce a biennial minority health status report. This report contains an overview of the health status of minority Kentuckians, identifying the disease and conditions experienced at disproportionate mortality and morbidity rates within the minority populations, and how to make recommendations to meet the identified needs of those minority populations. The Minority Health Status Report is located on the Office of Health Equity webpage. A few highlights and key findings of that report include the following. Racial and ethnic minorities are more likely to own their own homes in Kentucky. Blacks and Hispanics are more likely to have no health insurance coverage in Kentucky. Cancer and heart disease are the two leading causes of death in Kentucky for all races and ethnicities. Blacks have the highest prevalence of diabetes in the state of Kentucky and the highest obesity rates in the state as well. That report also looks at some of the social indicators linked to poor health outcomes, which is education and home ownership and insurance. In addition, I'm sure if you haven't heard by now, you will, about the Governor's Initiative for Kentucky Health Now. And that initiative is looking at a comprehensive plan to address some of those disparate rankings that I shared with you earlier. We also have the State Health Strategic Plan, Healthy Kentucky 2020, which looks at health equity and addressing health disparities. Currently, we're working on aligning all of those guiding documents to be in line with the Governor's Kentucky Health Now, so we can all be trying to make a greater impact by all being on the same page. In addition, we have the smoke-free policy for our state. We currently have two bills, House Bill 173 and Senate Bill 119, currently looking at smoke-free laws, smoke-free policy for the state of Kentucky. The Health Bill 173 is in the orders of the day, which can be called up at any time. And Senate Bill 119 is just a little different, looking at raising the revenue, and it is still in committee. So we're looking at how to address health equity in the state. And some of the figures that we are currently looking at and very proud of is the Health Benefits Exchange and Kentucky Connect. Prior to instituting Connect, 15% of the state's population was uninsured prior to the start of October 1 of 2013. As of February the 14th of 2014, we have about 108,000 Kentuckians enrolled in health insurance through Connect that are under the age of 35, which is about 47% of all of the enrollments. And the private health plans, about one-third of all of the enrollees 32% are under the age of 35. So we're making roads and providing access to all Kentuckians. So that's something to be very proud of. And I think you heard Amira say that Kentucky is the only state in the South to be doing expanded Medicaid. Next slide, please, talking about Kentucky Health Now in general. There's 7 areas in particular that Kentucky Health Now will focus on, one of those being health insurance and access. The other will be smoking, obesity, cancer, cardiovascular disease, dental decay, and drug addiction. And I wouldn't be remiss in adding the last slides on smoke-free Kentucky. No amount of secondhand smoke is safe. And the reason that we need a smoke-free policy, next slide please, is the gentleman Jameson that you see pictured at the left. That he was exposed to secondhand smoke at his workplace, and he had to present to the emergency room. And it's for young folks and everyone like Jameson that we want to do something, last slide please, to ensure that we have comprehensive smoke-free laws, because 100% of all Kentuckians deserve this protection. I thank you. If you have any questions, I'd be happy to answer them at this time.
Thanks so much, Vivian. If you all have questions for any of our speakers, feel free to chat those questions over, and I can get those to our speakers. A reminder that this webinar and all of the associated slides will be posted to the Foundation's website, where you can check that out. It'll take us about a week to get that posted, but you can check it out on our website, healthy-ky.org. Again, I want to thank all of our speakers today for the fantastic information on health equity. Gabriella gave us a broad scope on what the theory is behind health equity, and Amira gave us a real practical application, and Vivian clued us into what's going on in Kentucky with some of the new initiatives, Kentucky Health Now, and those updated Connect numbers. Extremely exciting. And I want to thank you, all of our participants who joined us today, for taking part of this Foundation for a Healthy Kentucky Health for a Change webinar. I want to remind you, March 14th is our next Health for a Change event, which will be a business planning workshop held here in our Louisville office. That event is free and open to the public. You can find the registration link on the Foundation's website. If you would, kindly this afternoon when you receive an email from us, that's the post-event evaluation, take a few minutes, complete the evaluation, let us know your thoughts about today's webinar, and also if you have ideas for other webinars or trainings that you all are interested in, happy to put that on the docket for the Foundation's Health for a Change training series. Thank you so much for your time today. Have a great afternoon.
And ladies and gentlemen, that does conclude our webinar. We thank you for your participation and ask that you please disconnect your line.